and the topic is local anesthetics. Local anesthetics are drugs which, when applied topically or injected locally, block nerve conduction and cause reversible loss of all sensations in the part supplied by the nerve. The order of blockade of nerve function proceeds in the following manner: pain, temperature, touch, pressure, and finally skeletal muscle power. Now, chemistry. Local anesthetics are weak bases. They consist of three parts: hydrophilic group, lipophilic aromatic group, and intermediate ester or amide linkage. Now, the classification of local anesthetics. First, according to clinical use, they are of two types: surface anesthetics and injectable anesthetics. Where injectable anesthetics, these are of three types: short acting with low potency, that is procaine and chlorprocaine. Second is intermediate acting with intermediate potency, that is lignocaine, mepivacaine, prilocaine, and articaine. Long acting with high potency, that is tetracaine, bupivacaine, dibucaine, and ropivacaine. Second is according to structure, that are first esters, that is cocaine, procaine, chloroprocaine, benzocaine, and tetracaine. Second is amides, that is lignocaine, mepivacaine, bupivacaine, prilocaine, articaine, and ropivacaine. Now, mechanism of action. Local anesthetics act on voltage sensitive sodium channels, where sodium channels exist in resting, open, and inactivated states. The channels have to recover from the inactivated state to resting state before they can be opened in response to an impulse. The local anesthetics, unionized, form easily penetrate nerve sheath and axon membrane. Within the exoplasm, the molecules become ionized and block the voltage-gated sodium channels. Local anesthetics are weak bases. At tissue which has a pH of 7.4, it causes partial ionization, which then penetrates the nerve membrane, then enters the axon as axonal pH is low. Reionization of the local anesthetics, then they gain access to its receptor in the open state of the channel. Local anesthetics block the voltage-gated sodium channels from inside, binds more tightly to inactivated state, and prolongs the inactivated state. Then prevents entry of sodium ions into the neuron, and then decreases the rate of depolarization, then prevents the generation of action potential, then no generation and conduction of impulses to the CNS. That local anesthesia. Now, blockade is frequency dependent. Action of local anesthetics is pH dependent, and the penetrability of local anesthetic is increased at alkaline pH, that is, when the unionized form is more. Penetrability is very poor at the acidic pH of tissues. In infected tissues, there is a low pH which causes ionization of the drug. This reduces the penetration of local anesthetics through the cell membrane, thus decreases the effectiveness of local anesthetics. Therefore, local anesthetics are less effective in inflamed and infected areas. Diameter of nerve fiber. Local anesthetics blocks small fibers first, followed by the large fibers. Myelinated fibers are blocked earlier than the non-myelinated nerves of the small diameter. Sensory fibers are blocked earlier than motor fibers because of their high firing rate and longer duration of action potential. Fibers in the center are blocked later than the ones located in the circumference of the nerve bundle. Now, what are the factors affecting the local anesthetic action? First is pKa value. Higher the pKa, more is the ionized fraction of the drug at physiological pH. Hence, onset of action is slow and vice versa. Example, the pKa of procaine is 9.1, hence it has the slow onset of action, whereas pKa of lignocaine is 7.7. It has rapid onset of action. Second, degree of plasma protein binding. Higher the plasma protein binding, longer the duration of action of the drug. Example, procaine is poorly bound to plasma proteins, hence has a short duration of action, whereas bupivacaine is highly plasma protein bound and has longer duration of action. Third is rate of diffusion from the site of administration. Now it depends on the initial concentration gradient of the drug. Higher will be the concentration, rapid is the onset of the action. Now lipid solubility. Fourth one, higher the lipid solubility, more is the potency of the drug. Example, lignocaine is more potent than procaine as it is more lipid soluble. Fifth is presence of vasoconstrictor. It prolongs the duration of action of local anesthetics. The commonly used vasoconstrictor with local anesthetic is adrenaline. Now next, combination of vasoconstrictor with local anesthetics. Addition of vasoconstrictor like adrenaline to the local anesthetic has the following advantages. First, slow absorption from the local site, which results in prolonged duration of action of local anesthetics. Second, decreased bleeding in the surgical field. Third, slow absorption of local anesthetic reduces its systemic toxicity. Now, what are the disadvantages and contraindications of combining vasoconstrictor with the local anesthetics? First is intense vasospasm and ischemia in the tissues with and arteries may cause gangrene of the part. Example, fingers, toes, penis, ear lobule, tip of nose, etc. Hence, use of vasoconstrictors is contraindicated in these sites. Second is absorption of adrenaline can cause systemic toxicity. And can cause tachycardia, palpitation, rise of BP, and precipitation of angina or cardiac arrhythmias. Hence, combined preparation LA with the adrenaline should be avoided in patients with hypertension, congestive cardiac failure, arrhythmias, ischemic heart disease, and uncontrolled hyperthyroidism. Third is, it can delay wound healing by reducing the blood flow to the affected area. Now, what are the pharmacological actions? First, in nervous system, peripheral nerves. Autonomic fibers are blocked earlier than somatic fibers. Sensation of pain disappears first, followed by the temperature, touch, pressure, and motor functions. Second, CNS. Most of the local anesthetics cross the blood-brain barrier. Initially, they cause CNS stimulation and then depression in higher doses. They cause excitement, tremor, twitching, restlessness, and convulsions. Large doses can cause respiratory depression, coma, and death. Second, in cardiovascular system. Then in heart. Local anesthetics, by blocking sodium channels, decrease abnormal pacemaker activity, contractility, conductivity, excitability, heart rate, cardiac output, and increase effective refractory period. Then, at higher concentrations, intravenous administrations of local anesthetics may precipitate cardiac arrhythmias. Bupivacaine is more cardiotoxic than other local anesthetics, may cause cardiovascular collapse and death. Whereas lignocaine, it decreases automaticity and is useful in ventricular arrhythmias. Now, in blood vessels, local anesthetics produce hypotension due to vasodilatation and myocardial depression. Now we'll talk about the pharmacokinetics. Most of the ester-linked local anesthetics are rapidly metabolized by plasma cholinesterase, whereas amide-linked drugs are metabolized mainly in liver. Local anesthetics like procaine, lignocaine, etc. are not effective orally because of high first-pass metabolism. In liver diseases, the metabolism of lignocaine may be impaired, hence dose must be reduced accordingly. Comparative features of esters and amides are shown. Now, adverse effects of local anesthetics in CNS. It initially causes CNS stimulation followed by depression. They are restlessness, tremor, headache, drowsiness, confusion, convulsions, followed by respiratory depression, coma, and death. In CVS, it causes bradycardia, hypotension, cardiac arrhythmias, and rarely cardiovascular collapse and death. Bupivacaine is highly cardiotoxic. Now, allergic reactions. These are skin rashes, itching, erythema, uh, urticaria, wheezing, bronchospasm, and rarely anaphylactic reaction. The incidence of allergic reactions is more with ester-linked local anesthetics than with amide-linked local anesthetics. It causes mucosal irritation, cocaine, and methemoglobinemia. Prilocaine may be seen. Methylparaben, um, preservative in local anesthetics preparation, may cause allergic reactions. Procaine. It is a prototype drug for esters. It is rarely used now because of availability of better agents. Second is lignocaine. It is a prototype agent for amides. It is very popular anesthetic used widely for topical applications. Infiltration, spinal and conduction block anesthesia. It is also available as a patch. Can be used to control severe pain of post-therapeutic neuralgias. Tetracaine, an ester type of local anesthetic. It has a long duration but slow onset of action. It is useful for spinal anesthesia because of its long duration of action. It is mainly used as surface anesthetics for eye, nose, and upper respiratory tract. Bupivacaine. It is a widely used local anesthetic. It is potent and has a long duration of action. It produces more sensory than motor blockade, hence very popular for obstetric analgesia. It is highly cardiotoxic and may precipitate ventricular arrhythmias. Levobupivacaine. It is similar to bupivacaine but less cardiotoxic and less likely to cause seizures. Ropivacaine. It is less potent and less cardiotoxic than bupivacaine. Its duration of action is similar to bupivacaine. It is used for both epidural and regional anesthesia. It is more selective for sensory fibers than motor fibers, hence used in obstetric analgesia. Prilocaine. It is an amide type of local anesthetic. It has intermediate onset and duration of action. It has poor vasodilatory effect, hence can be used without a vasoconstrictor. Prilocaine is not suitable for labor pain because of the risk of neonatal methemoglobinemia. It is mainly used for infiltration and IV regional anesthesia. Cocaine. It is an alkaloid, excellent surface anesthetic but rarely used because of its addiction liability. Then eutectic mixture. Eutectic mixture of local anesthetics, lignocaine 2.5% and prilocaine 2.5%, which is called EMLA. The melting point of the mixture is less than that of either compound alone. It can anesthetize intact skin. EMLA has to be applied 1 hour before the procedure and is used for dermal anesthesia during venesection and skin graft procedures. It should not be used on mucous membranes or abraded skin. It is contraindicated in patients with methemoglobinemia and infants. Dubucaine. It is very potent, highly toxic, and the longest acting local anesthetic. It is rarely used for spinal anesthesia and is also available for topical applications on mucous membrane and skin. Benozinate. It is a surface anesthetic useful for corneal anesthesia. Benzocaine and butyl aminobenzoate. Surface anesthetics cause minimal systemic toxicity, available as ointment and lozenges, used for hemorrhoids, anal fissure, and sore throat. Oxythazine. It is a topical anesthetic and is used to anesthetize gastric mucosa. It produces symptomatic relief in gastritis. It is available in combination with antacids. Now, techniques of local anesthesia. Surface anesthesia, which is also called topical anesthesia. Local anesthetic is applied on the abraded skin and mucous membrane of the nose, mouth, eyes, throat, upper respiratory tract, esophagus, urethra, and ulcers, burns, fissures, etc. Motor function is intact. Tetracaine 2%, lignocaine 2 to 10%, benzocaine 1 to 2%, etc. are used for topical applications. Surface anesthetics are available as solution, ointment, gel, jelly, cream, spray, lozenges, etc. Addition of adrenaline does not prolong the duration of surface anesthesia because of poor penetration. Topical anesthetics are useful in many diagnostic procedures like tonometry in eye and during endoscopies. EMLA is used to anesthetize the intact skin and structures in the superficial subcutaneous tissue. Infiltration anesthesia. Local anesthetic is injected directly into the tissues to be operated. It blocks sensory nerve endings. The most frequently used local anesthetic for infiltration are lignocaine 0.5 to 1%, procaine 0.5 to 1%, and bupivacaine 0.125 to 0.25%. Addition of adrenaline to local anesthetic, that is 1 is to 50,000 or to 250,000, prolongs the duration of anesthesia. Infiltration anesthesia is suitable only for small areas. The main disadvantage of infiltration is the requirement of large amount of the drug to anesthetize relatively small area. It can be used for drainage of an abscess, excision of small swelling, suturing of cut wounds, episiotomy, etc. Infiltration anesthesia is contraindicated if there is local infection and clotting disorders. Conduction block. We have two types. First, field block anesthesia. It is achieved by injecting a local anesthetic subcutaneously which anesthetizes the area distal to the injection. This principle is used in case of minor procedures of scalp, anterior abdominal wall, upper and lower extremities, in which a smaller dose produces large area of anesthesia. Second, nerve block anesthesia. Local anesthetic is injected very close to or around the peripheral nerve or nerve plexus. It produces larger area of anesthesia than field block. Brachial plexus block for procedures on upper limb. Cervical plexus blocked for surgery of the neck. Intercostal nerve block for anterior abdominal wall surgery, and sciatic and femoral nerve block for surgery distal to the knee. In this procedure, the requirement of local anesthetic is less than that of the field block and infiltration anesthesia. Now, spinal anesthesia. It is one of the most popular forms of anesthesia. Local anesthetic is injected into the subarachnoid space to anesthetize spinal roots. Site of injection. Spinal anesthetic is injected into the space between L2 to 3 or L3 to 4 below the lower end of the spinal cord. The level of anesthesia is influenced by site of injection, amount of fluid injected, force of injection, specific gravity of the drug solution, which is hyperbaric in 10% glucose, hypobaric in distilled water, or isobaric, and position of the patient, lying, prone, lateral or tilted with head down position. Local anesthetics used for spinal anesthesia. They are lignocaine, tetracaine, bupivacaine, etc. Addition to adrenaline to spinal anesthetic increases the duration of intensity of block. Now, what are the uses? Spinal anesthesia can be used for surgical procedures below the level of umbilicus, that is, lower limb surgery, cesarean sections, obstetric procedures, prostatectomy, surgery on perineum or appendectomy, etc. Now, what are the advantages of spinal anesthesia? No loss of consciousness, good muscle relaxation, and good analgesia. Patients with cardiac, pulmonary, and renal diseases they tolerate spinal anesthesia better than general anesthesia. Now, what are the complications? Headache is due to CSF and can be reduced by using very fine needle Hypotension is due to blockade of sympathetic vasoconstrictor fibers to blood vessels. Venous return to the heart is reduced due to paralysis of skeletal muscles in the legs. Hypotension is treated by raising foot and administration of sympathomimetics such as ephedrine, mephentermine, phenylephrine, etc. Respiratory paralysis. It is due to paralysis of intercostal muscles. Respiratory failure may occur due to respiratory central ischemia as a result of hypotension. Septic meningitis and nerve injury are extremely rare at present because of good anesthetic practice. Post-operative urinary retention may occur. Now, what are contraindications? Spinal anesthesia should not be used in young children, vertebral abnormalities, sepsis in the region of lumbar puncture site, or hypotension and shock. Now, epidural anesthesia. Local anesthetic is injected into the epidural space, thoracic or lumbar region or sacral canal, where it acts on spinal nerve roots. Lignocaine and bupivacaine are commonly used. It is safer, but the technique is more difficult than spinal anesthesia. Epidural anesthesia is slower in onset than spinal anesthesia. It requires a much larger amount of the drug. Epidural analgesia is being used in obstetrics during labor. Low concentration of bupivacaine or ropivacaine is used to block pain sensations without significant motor block. Ropivacaine is less cardiotoxic and motor blockade is less than bupivacaine. Intravenous regional anesthesia, which is also called Beer's block, BIERS, Beer's block. It is mainly used in anesthetizing the upper limb. Lignocaine and prilocaine are commonly used. Local anesthetic is injected into vein of the limb in which the blood flow is augmented by a tourniquet. Drug interaction. Lignocaine with propranolol. Propranolol, by reducing hepatic blood flow, impairs the clearance of lignocaine, which may result in toxicity. Procaine with sulfonamides. Procaine is hydrolyzed by PABA, reduces the effect of sulfonamides. Thank you. And the